The HFpEF trial, semaglutide in patients with heart failure with preserved ejection fraction and obesity. And as you can see, there was significant Canadian contribution to this study. HFpEF accounts for more than half of all heart failure cases, with majority of whom are obese or overweight, with few efficacious treatments available. The obesity HFpEF phenotype has unique clinical and hemodynamic features and is associated with an especially high burden of symptoms and functional impairment. Semaglutide is a potent once-weekly GLP-1 receptor agonist, which produces substantial weight loss in individuals who are overweight. There are many mechanisms or potential mechanisms to postulate the effects or benefits of semaglutide in the obese phenotype of HFpEF. They include both weight loss-related mechanisms on the right of the screen and weight loss-independent mechanisms shown on the left. So 529 patients were randomized to either subcutaneous semaglutide with a target dose of 2.4 milligrams subcutaneous once weekly versus placebo. Subjects were treated for 52 weeks with a 5-week follow-up. Key inclusion criteria included left ventricular ejection fraction greater than or equal to 45% with an NYHA functional class 2 to 4, a KCCQ score less than 90, 6-minute walk test greater than 100 meters, and one of the following criteria listed below. Key exclusion criteria were prior or planned bariatric surgery, recent weight change, recent adverse cardiovascular event or heart failure hospitalization, hypertension, or known history of diabetes. Here are the baseline characteristics. Majority of patients in the trial were white women. The median age was 69. Average body weight was 105 kilograms, which is about 230 pounds, with 2/3 of the patients having a BMI greater than 35 kilograms per meter squared. The average left ventricular ejection fraction was 57%, and most patients had NYHA class 2. The median KCCQ score was 59, which is consistent with substantial symptomatic and functional impairment. The median 6-minute walk distance was only 320 meters at baseline, and the median NT-proBNP was 451. Most patients received background therapy of beta blockers, RAS blockers or ARNI, and loop diuretics. About a third received a mineralocorticoid receptor antagonist. Very few patients were on an SGLT2 inhibitor. Here is part 1 of the dual primary endpoint. The semaglutide group had a significantly greater improvement in their KCCQ score compared to placebo. This was evident early in the trial and became more amplified as the trial went on. At 52 weeks, there was an estimated treatment difference of 7.8 in favor of semaglutide. P-value was less than 0.001. The second primary endpoint was change in body weight. Again, there was an early benefit with semaglutide, amplified as the trial went on. At 52 weeks, the treatment difference was 10.7%. Patients treated with semaglutide had significantly greater improvement in their 6-minute walking distance, with a treatment difference of 20 meters, p-value less than 0.001. If you look at the confirmatory secondary endpoints, semaglutide produced more win ratios of clinical benefit versus placebo, 60% versus 35%, giving a win ratio of 1.72. Of note, there are more wins with every component of this hierarchical composite with semaglutide. There were fewer serious adverse events in patients treated with semaglutide. This was predominantly accounted for by fewer cardiac disorders. There was no difference in all-cause death. There was no difference in discontinuation rates due to serious adverse events, but not surprisingly, more people stopped semaglutide due to GI adverse events. In conclusion, in patients with HFpEF and obesity, semaglutide improved heart failure-related symptoms, physical limitations, and exercise function, reduced inflammation, and resulted in greater weight loss as compared to placebo. The magnitude of benefit was large, clinically meaningful, and highly statistically significant. It also resulted in lower markers of congestion and heart failure events, suggesting important disease-modifying effect. It was well tolerated with significantly fewer serious adverse events compared to placebo. Collectively, these results indicate that treatment with semaglutide is a valuable therapeutic approach in the management of patients with HFpEF and obesity.